This is a session that was designed together with Women as One. And this is a tradition that started last year, and I hope that it will continue.
And we will keep it.
We will keep it, and it just gives the idea how much as European Bifurcation Club we are for inclusivity and equity. I mean, we like to have inclusivity and equity. And so there was a call that went also through the Women as One website asking for complication cases in bifurcation. There were a number of persons that submitted their case, and then the board decided and other members of European Bifurcation Club. So this was really transparent and open call for cases, and then the cases were analyzed and there were some votes given. And so the ones that are going to present are the ones that have been selected among a number of different cases. It's a pleasure for me clearly to chair this together with Goran, together with Valeria, and together with Jas. I hope I'm doing a crisis of the name, it's complex. And in the panel, it's going to be Stefan, Harb, Jozica, I hope it's correct, Adel, and Sarita. I mean, my she's online, okay? So it's a pleasure to present the first case that was selected, that is when a complex lesion is not your biggest problem. The presenter, it's another very complex name for me. So maybe if you... Sylvia? W is like V, Sylvia.
That's
okay.
Right.
So please.
Thank you very much, dear Chairman. It's a great honor to me to present at EBC 2023 meeting. So the title of my presentation is When a Complex Lesion is Not Your Biggest Problem. So let me present the clinical characteristic. It's an 80-year-old male presented with non-STEMI, with multivessel disease and left main stenosis, who was disqualified from coverage because of the high surgical risk. So he had previous STEMI of inferior wall treated with primary PCI. He suffered from heart failure with reduced ejection fraction 35%, atrial fibrillation, hypertension, hyperlipidemia, diabetes mellitus type 2, and nicotine dependence. As you can see in coronary angiography, there is a critical stenosis in distal left main with involving the proximal part of Alaide and circumflex artery, so the medina is 111. During the predilatation, I was unable to cross the lesion with a larger balloon than 1.5 millimeter balloon due to severe calcified lesion. So I decided to do the rotablation of Alaide with 1.5 balloon bore. After that, you can see there is any significant dissection, so I decided to do the rotablation, also the circumflex artery, because of the difficult angulation of the coronary artery and also calcified lesion in the ostium of coronary artery. So after the rotablation, I exchanged the wire into cyan blue extra support, both into the circ and the left and the Alaide. Next, I did the predilatation with 2.5 NC balloon. It was effective predilatation with full expanded balloon. This is an angiographic results without any significant dissection with TIMI 3. And because of the complex lesion Medina 111, I decided to do the DK crush technique. So I started with the DS implantation 2.5 20 millimeters into the circumflex artery and left main. After that, I crushed the stent with balloon 3.5 and next 4.5 at the pot position. After the rewiring, I did the first kissing balloon with 2.5 and 3.5 balloons. Next, in the next step, I implanted the stent, DS 3.5/24, with the coverage of whole left main from the ostium. Of course, I did the pot with 5 NC balloon. After the rewiring, I did the second kissing balloon with 2.5 and 3.5 NC balloons, and after that, I finished the procedure with a repot with 5 NC balloon. As you can see, there is a IVUS imaging after the procedure. The lesions are quite diffused. There is a eccentric plaque in the mid and distal left Alaide with calcification, ring calcification in the mid segment of Alaide. But at the end of the stent, there is plaque burden. We will see that. Yes, there is a plaque burden less than 15%. The good expansion of the stent in Alaide and left main. There was a bifurcation with circ. And the expansion of the stent in the left main is also well with the short protrusion of the stent into the aorta. And I'd like to show you the final angiographic results. And after that, I would like to ask you for a discussion. So I will show you one more time the angiographic results.
Thank you very much. Excellent procedure. Now it's open for comments and discussion. It reminds me very much to one case that Colombo did live for TCT. And for the last image, he wanted to push a wire to disengage the guiding catheter. And he ended up exactly like this with the distal perforation. So any comments or questions?
One more time, please. The wire
extra
was
support
extra
cyan.
support cyan blue in both circle and Alaide. Yeah, and the perforation, of course, was not visible before the wiring removal. So,
Dr. Javik, can we have microphone here?
one. Without the fluids in the first visualization in echo, so it was so huge at the beginning, but after that I will show you the situation changed.
Vlad?
You used a 2.5 stent in the circumflex?
That's right.
Okay, and did you IVUS the circumflex? We didn't see that.
Yeah.
I just don't see a circumflex being a 2.5
At the beginning,
ever.
yeah, at the beginning, I couldn't pass the sound through the lesion in Alaide and circumflex artery, so it was impossible. And after the procedure, unfortunately, I didn't do it because of the angulation of the circumflex was quite difficult, so it was impossible.
And so you didn't try to IVUS after rota then?
I tried to do the IVUS after the procedure, but
No, I don't mean after the procedure, after you stented, but after rota.
No, I
Yeah,
didn't.
so I that would be my only comment, is that's kind of the time, so you know what size of stent. But in my experience is proximal circumflex arteries are not 2.5 ever. I don't know what other
Valeria.
people think, but that stent needs to be bigger.
Sylwia, a question. Great case. Why did you choose an extra support cyan blue wire? Because the vessel was not a tortuous, and you had already good access, and the position also of the rota wire was good. So this is a wire which has a tip which is kind of soft, but is a support wire which can be used for really tortuous lesion and calcified. So why did you go for this wire?
Thank you for this question. Unfortunately, the position of the guide wire wasn't excellent. It was EBU 3.5 French, but it's not so stable. So I wanted to get more support.
Yeah, was calcified the rota,
Yeah.
and then was difficult probably to predict.
That's right.
To be honest, cyan blue wire has a hydrophobic tip, so it's really not prone to perforation. So probably you were stuck in maybe a small branch or something like that. But that's maybe a reason. But it's, for me, in my experience, that are very safe wire. So I think it was a good choice, actually. A question about the use of rotablation. Do you think in such a case, I mean, or a question to the audience, that's probably a good case also for shockwave because you're proximal, the access is relatively easy. I think it's not a bad case for a shockwave.
Yes, but
She
unfortunately,
could not cross with the balloon.
The lesion was not
The 1.5
crossable.
didn't cross?
1.5, it's the biggest one, which I
Didn't
crossed the
cross?
lesion.
Okay.
The bigger one, it's
Sorry, okay.
impossible.
Sorry for that.
to
Okay,
cross,
but
so.
then you answered the question.
No, I think you did an amazing job in really prepping the lesion. It's a difficult case, and you did rotablate up both limbs. Shockwave would not cross, obviously, with that angle. Did you see the circumflex? You can actually cut the wire the way you were rotablating, which is goes like that. The wire folds backwards, and you run the risk of cutting wires to it, but you did a good job. So the case was good. It happens to us too. What happens is when we try to do multiple exchanges, multiple recross, multiple balloons, sometimes we forget where our distal wire is. We tell the fellows that all the time. We all have gone through these things. So I think your wire choice was decent. I think the tip is decent. I think, unfortunately, it went into a little branch, and we're going back and forth. But you did an excellent job in the case. You really did.
Thank you.
Did you have to inflate balloon to stop this, or you finished?
Yes, I will show you in
Okay,
the next
please.
slides. Okay, so let's go. So it was, of course, my first step to inflate a small low-pressure balloon proximally to the perforation, and of course the additional support of the blood pressure. But despite the many attempts and many inflation with low-pressure balloon, there is still blood leakage. So the next step was embolization by autologous fat particles. As you can see, through the microcatheter introduced distally to the artery, I tried to embolize the artery, but unfortunately it was unsuccessful. The patient developed cardiac tamponade, so the pericardiocentesis was necessary. We have to try another solution of this problem. So we decided to close the artery with the coil. So I put 3 coils distally into the artery, and fortunately the bleeding was stopped. Oh. Okay, so this is the angiographic final results. There is some myocardial blush in the place of the balloon, but there is no bleeding distally through the artery. So the angiographic result was good. Unfortunately, after 4 hours, the patient's clinical conditions deteriorated due to the recurrent cardiac tamponade. We tried to, because it was on my duty, so we tried to another pericardiocentesis. It was ineffective, so we, due to the cardiac arrest, we did the urgent thoracotomy with pericardial sac decompression, and after the open cardiac massage and epicardial electrode implementation, we returned the hemodynamically efficient circulation. But unfortunately, after the 1 day, during the next day, the patient died because of the severe metabolic acidosis and multi-organ failure. So let's go to the conclusion. The distal coronary perforation is often due to the guide wire related vessel injury. and it's more common with hydrophilic wires, as in our case. A looped wire tip is safer than a straight tip, reducing the inadvertent migration into the distal segment and small branches. And with extensive damage to the small vessel, bleeding may continue despite occlusion of the main supplying artery. Thank you very much.
Thank you very much for sharing this. Dr. Girazis, just a very brief comment, we need to go on.
Bearing in mind what happened afterwards, I mean, did you consider trying the ping pong maneuver that you keep the balloon inflated and get a second guide and then win some time without the patient extravasating in the pericardial sac and blah, blah, blah?
It was a common decision, cardiologists and cardiosurgeons, so we
I mean, during the first phase, during
during the first case. So
before actually bringing in the coils, etc., just bringing in a second guide via the groin, and then keeping the balloon inflated, working there, and saving time and saving blood.
Yeah, of course, isn't an option. It was considered, but during the all maneuvers, which I did, I was keeping the balloon inflated in the artery, so the bleeding meantime was not so big a problem. And during the putting the coils, the balloon was also inflated, open, so which stopped the bleeding. Okay. But of course, it's an option also.
Yeah. Okay. I think we really need to go on. Thank you very much for sharing this. This is really extremely complex case. Unfortunately, ended up with the patient death, but thanks for sharing that. We learn a lot. Thank you, Sylwia.
It was a pleasure. Thank you very much.
So I would like to invite now Nick.
We will vote at the end of the session because for the moment, I think it's not working properly.
It's also better that we see all the cases. So Nicola Ryan, crushing the complication.
Great. Thank you very much for the invitation to present. So this case is a 78-year-old gentleman. I had seen him in the clinic back in February of this year with typical exertional chest pain and some dyspnea. Doesn't have too much in the way of cardiovascular risk factors and was on 2 anti-anginals. His echo had showed some mild LV impairment, a bit of hypokinesis of the posterior wall. His labs were essentially unremarkable, and you can see his ECG down in the bottom right-hand corner. So on this basis, I offered him a diagnostic angiogram, which we might get, yep. You can see his right here, you know, a bit of minor plaque, nothing too impressive. And then we see he has a Medina 111 in his Alaide diagonal bifurcation. And then he has a left main Alaide circ intermediate trifurcation disease as well. So he was discussed obviously for various treatment options, and at the end of the day it was decided that he would come for PCI. So the initial setup was right radial access, 7 French, an EBU 3.5 guide, and 4 scion wires, a scion wire to the circ and to the intermediate, a scion wire to the Alaide, that was all relatively straightforward, and a scion wire to the diagonal, which was a little bit more tricky to wire, but with a little bit of reverse wiring was wireable. After this, I then went on to IVUS, the circ, the intermediate, the diagonal, and the Alaide. For the interest of the case, I'm just going to show you the diagonal and the Alaide. So this is his mid-diagonal, where we've got a relatively healthy landing zone of about 2.5 to 3 millimeters. I don't seem to be progressing. Oh, we've gone on too far now, sorry about that. This is his ostial diagonal, his mid-Alaide, his ostial Alaide, and his left main stem, where we've got a diameter of about 5 to 5.5 millimeters. So given the difficulties with wiring the diagonal with the presence of the disease, I decided to initially do an inverted culotte strategy in the LAD diagonal and then plan for a provisional strategy for the left main LAD. So nobody is particularly interested in the huge steps of the PCI. It was relatively straightforward, 2.75 by 33 Zions into the diagonal back to the LAD, recrossed, did the first kissing balloon, did a distal LAD stent because the healthy landing zone was distal to the bifurcation, stented back to the proximal LAD, all pretty unremarkable at this point in time. Started to post-dilate, so it had taken a 3.5 by 15 millimeter NC emerge because we didn't have anything longer on the shelf to post-dilate. And then again, all unremarkable. And at this point in time, taking the post-dilatation balloon out of the LAD, unfortunately, everything comes out, including the wire in the diagonal, the wire in the LAD, the wire in the circ, and the wire in the intermediate. So, multiple attempts to wire back into the LAD and can't get back into the true lumen of the vessel, continually wiring abluminally. And I've IVUSed this on multiple occasions, and I'm still through the first basically 2 to 3 struts of the proximal LAD stent. So what next?
Okay, so suggestions? Dr. Harb, can we have a microphone here in the first row?
So if you're planning to do a provisional in the left main, why don't you bring the LED stent all the way back in the left main? And then potted it, and then maybe you'd have a better chance.
Yep, so that was a really good question, and this is something that I had thought about. So my issue was, first of all, I wouldn't have been able to take a long enough stent right back to the left main. And my second issue was that I was concerned if I had come right back to the left main and I had jailed my wire into the diagonal, when I was removing that jailed wire, I would have a risk of having longitudinal stent deformation of the left main stem stent. So that was why I had decided to treat the LAD diagonal bifurcation first and then come back and complete the second bifurcation. Pardon? So no, the wire is no longer inside the LAD stent. When the non-compliant balloon came back, there was inadvertent removal of the wire. So the wire has come out of the LAD, and despite multiple attempts, looping wires, and I cannot get through the lumen of the stent. I'm continually abluminally for the first 2 or 3 struts.
So if the wire is going abluminally for the first 2 stent struts, it's very difficult to wire the true lumen again. So just put a short stent in the proximal part of the stent, and then it will connect to the true lumen distally. Optimize that proximal part of the stent with a bigger balloon and then continue distally. Probably is what the solution is for this problem generally.
Okay. So what I did was I decided that I wasn't going to be able to get into the lumen of the stent, so I needed to crush the first few struts of the stent. So I started off with just a 1.5 by 15 millimeter small balloon, and I worked essentially all the way up to a 3.5 millimeter balloon. Could the technical team please press play on that bottom image? Could you hit play on the, thank you. So once I had crushed essentially the stent with a 3.5 balloon, I then did an IVUS run back from the LAD. And you can see, while it's not completely optimal, there's a relatively good, and here we see just between 11 and 1, the crushed stent. So I just have some images. This is the distal stent. Here we're at the crushed proximal stent. Again, we see it crushed here. And this is again back into the proximal vessel.
The crushed segment is in left main?
No, it's in the proximal LAD.
Proximally.
Proximal LAD, yeah.
There's an acoustic shadow of a second wire. Did you wire the diagonal too before that?
No, I did actually, yeah, sorry.
So there are 2 wires there.
Yeah, but what I had done, so I've not gone the whole saga that this was when I was doing the case for this, but yeah, no, I had wired the diagonal then.
So here's the issue. Are both wires through the same strut? You're crushing the proximal part of the stent that's going into the LAD. So for that to work, both wires have to have gone through the same strut.
Yeah, no, so what I did was I crushed it, then I wired into my diagonal, and then I've done my IVUS. I can't see who's speaking to me, sorry. So then I went on and stented the left main to the LAD with a 4023. Did my second kissing balloon in the LAD diagonal. Did kissing balloons in the left main into intermediate and then left main into circ. Did a final pot. Did a final IVUS run. This is the distal LAD, mid, proximal, and left main. And this is the final angio in a caudal. And up here in a cranial view. So basically, my key learning points from this case were that dual bifurcations are a challenge. As suggested, you can either treat one of them completely, come back straight to the left main, and then deal with the second part of it. In this case, I had planned to complete the first bifurcation to avoid jailing the diagonal wire back to the left main and risk longitudinal stent deformation. While all attempts to rewire luminae had failed, crushing the proximal stent struts is a reasonable strategy. Here, IVUS was key to ensure that they had actually been adequately crushed. And when you've got multiple wires, even when you're taking care, there is an increased risk of inadvertently removing the wire. So what was, for me, the most difficult part of the case, or getting the diagonal LAD stented, was relatively straightforward. What took up all the time in the case was completing the case. So we learnt a lot in the lab about paying attention to wires and not pulling on things. In this case, it wasn't me. In lots of cases, it has been me where I've pulled wires, so we've all done it.
Yeah, bravo, congratulations. Can we have microphone over there? And please come in the front part, because most of the people discuss here in the front part, so we need to have microphone here.
Thanks, Nicola. That was a great save. So just going to your last point, I was going to say, why did you have 4 wires? Because personally, I can't manage more than 2. I get confused. And as you say, the more wires you have, wire management becomes more difficult. So with dual bifurcations, I'd probably deal with 1, have 2 wires, and then deal with the second bifurcation in separate.
Yeah, I learned a tip actually from Goran of laying my wires out on the table the same way as I lay them out on the screen, and that's the way I typically manage my wires. With the best will in the world, these things happen.
Can we have microphone here?
You have 3 wires, you can prevent intertwining. You pull out, just inadvertently pull out something.
Take a microphone in order that
so
everybody...
if you have 3 wires, what she said was, she had a point. When you have 3 wires, there is an increased risk of pulling it out because there could be intertwining which you can't control.
Yeah, you can definitely get wire wrap. That's definitely a valid point.
What kind of wire do you have? Because there is a difference if you have a polymer-coated wire, heavy polymer-coated wire, and if in the case, if you have more than 3, I use some tips to put on the wire in different colors. So it's helped me to remind, and I also tell all my teams which kind of color I use for every kind of the vessel. So I think that's very helpful.
Yeah, I had 4 plain cyan wires.
And what kind of wire you use?
Just plain cyan. Cyan.
Last comment, Remo.
Yeah, A question to rewire luminally. Do you try a dual lumen catheter or not? You can use a dual lumen catheter on a abluminal wire. The tip will go luminal. Then you can mount a reverse wire, which is already looped, and then try to go.
No, I didn't do that. No.
This is a tip. Just
Yeah, excellent, excellent save. Nicola, thank you very much. Great case.
So we move on with Aninka Saboe. She's connected remotely. She's going to present a case of left main decay culotte stenting in iatrogenic ostial dissection.
Dear Chairman, thank you for the invitation to present at the EBC 2023 meeting. The title of my presentation is Left Main Decay Culotte Stenting in Iatrogenic Ostial Circumflex Dissection. This is a case of a 53-year-old man. He came to our clinic with symptoms of typical angina despite optimal medical therapy. His cardiovascular risk factors were hypertension and smoker. He underwent primary PCI at a district hospital 6 months ago, which revealed multivessel disease stenosis and left main disease, which at 2.75 DES was implanted at Ostial Alaide. And he also had underwent failed RCA CTO PCI 3 months ago at another hospital. LV ejection fraction was 41%, with regional wall motion abnormalities, and laboratory results revealed normal renal function. Here is the right coronary angiogram. We can appreciate here that there was CTO at proximal with branch collateral and JCTO score of 2. And here is the left coronary angiogram. We can appreciate here that the previous stent was visualized. However, we could not clearly identify whether the stent was nailed the ostium. And here is the still image. We can see here there was eccentric stenosis at left main, and the ostial Alaide and ostial circumflex were narrow, and there was also stenosis at distal circumflex, in which it was also donor collateral for RCA. It was decided to perform OCT-guided PCI to the left coronary artery to prepare retrograde PCI to the RCA CTO lesions. However, there were difficulties during the delivery of the OCT catheter. We can appreciate here that the OCT catheter was derailed from the wire and seems to be knocking at the circumflex ostium. And after repositioning the guiding catheter and after a more coaxial engagement, the OCT catheter was successfully advanced to the distal Alaide. And this is the left main Alaide OCT run, which revealed the prior stent was well expanded and opposed. However, the stent was not nailing the ostium. The OCT study revealed fibrotic plaque at ostial Alaide with MLA of 2.92 mm². We can also appreciate the eccentric lesion pointed by the yellow arrow at distal left main with MLA of 5.06 mm². We can also appreciate here there was an intimal tear at the ostial circumflex, which pointed by the red arrow. Suddenly, the patient was experiencing chest pain, and the ECG shown as the segment elevation at inferior lid, and careful contrast injection revealed dissection at the ostial proximal part of the circumflex with reduced antegrade flow and compromised collateral flow to the RCA. And we can appreciate here the location of knocked OCT catheter was similar to the dissection location. Our strategy was wiring multiple guide wires was used to ensure it was in the true lumen, followed by pre-dilation with 2.5 mm semi-compliant balloon, and after that, a 2.25 DES was placed at distal circumflex. DK Culotte stenting was performed with first stenting at the left main to circumflex, followed by POT and rewiring to Alaide and kissing balloon inflation with 3.0 NC balloon inflated up to 12 atmosphere. And the second stand was placed at the left main Alaide, followed by repot and rewiring to the circumflex. We perform final kissing balloon inflation with 3.5 NC balloon at left main Alaide and 3.0 NC balloon at left main circumflex, which followed by final POT using 4.0 NC balloon inflated up to 18 atmosphere. And here is the final OCT evaluation, which revealed no stent edge dissection, good stent expansion and apposition, and 3D OCT evaluation revealed no gel strut while preserving stent geometry. And this is the final angiogram. The patient symptoms were improved. Hemodynamic was stabilized with normalization of ECG. There are several points that we can learn from this case. First, lesion eccentricity might play a role in off-track OCT catheter delivery due to the complex intraluminal route. DK Culotte stenting is a feasible dual stent strategy for complex left main bifurcation PCI in bailout setting. And OCT usage is generally safe, but in cases with highly tortuous vessels, especially at the bifurcation site, the risk of dissection may occur. And that is the end of my presentation. Thank you.
Presentation is open for comments and discussion. Aninka, hello. Great case, another one today. Thank you very much.
Hi, thank you.
Congratulations on great save and very well illustrated. Do we have any comments? Eve? I think that both of you should be here in the front part.
My comment, friendly comment, is en place catheter is giving you a very strong support. But I think really this is not a catheter for left main because you cannot manage at least a small distance between the tip of the end of the catheter and the stent. And this was not your problem, but this is a great factor of longitudinal stent distortion. So really, my message is clear, don't use amplets for left main stenting.
Thank you.
Please.
Yes, just a minor comment on the OCT interpretation. I think you had a great save at the end, and I also believe that the OCT catheter was the reason for the dissection. On the OCT images, however, the small intimal tear that was seen can sometimes be an artifact. If the angle of incidence is very low, then sometimes you do not see very well at this point. So it cannot be evaluated as a tear itself.
Okay, thank you. But also it was impossible to perform OCT evaluation if we suspect dissection in these cases. Thank you.
Yeah, I just wanted to say in the first, the Amblets catheter was there, but then the guiding catheter was changed later on. I think what happened was that guiding dissected the left main and it did not progress to LAD because there was a stent in the LAD already. And the whole of the dissection from the left main went into the circumflex. So it's not probably that bending of the catheter which has dissected the circumflex, it's the guiding which has dissected the circumflex. but did not go into the LED because there was a stent already in the LED.
Yeah, thank you. Sarita, welcome to EBC this year. Now we see you on the screen. Do you have any comments?
I think it was a great save, Dr. Aninka. Thank you, Dr. Goran, for inviting me here. I think that the entire issue which she had with taking the OCT in was because of the wrong selection, probably of the guide catheter, which deflected the OCT. Especially in lesion situations like this, when we do the forceful injection to get the OCT images, this kind of situation sometimes arises. But I think in the end, she had a great save.
Exactly.
Thank you, Dr. Sarita.
So thanks for the case and thanks for having participated even if online. And so we move to the next case, which is the last case by Helen. Okay, she's here, Routledge. And it is Jailed or How to Get Out of It. I like the title, no? Very, very British.
British. Thank you. So, conflicts of interest. I'm female, but there were no females in the lab when this case was done. So this was sent in by my fellow for a complication session. And I think even I had a misunderstanding about whether my fellow was male or female, and he's actually male. So I'm presenting it on his behalf, and I wasn't in the lab. That's my excuse. It's not pretty at all, and a number of mistakes were made, but they are mistakes that we can learn from, but be warned. So 65-year-old gentleman who's a black belt in karate, and his title is the 4th Dan Shotokan. I don't know what that means, but it's quite important in the karate world. And he was admitted with a non-ST elevation MI with a reasonably high troponin, whatever troponin I means nowadays, but no history of any risk factors. He's very fit. That was his ECG, so we were expecting something in the proximal LAD, and he was taken to the lab on the second day of his hospital admission. So, as expected, he had a lesion in the proximal LAD and then another LAD diagonal bifurcation lesion in the mid. And this guy doesn't get pain. In the lab in France, we used to have an anaesthetist, which I quite liked. In the lab in the UK, we don't have an anaesthetist, and we just have a bit of diazepam. But this guy meditated all the way through his procedure, which, without giving the game away, went on for 7 hours. And he meditated, and he wasn't anaesthetized, and he doesn't complain of pain. But after this picture, he did actually have quite a lot of ST depression anteriorly, so we felt whatever the discussions about the circumflex, etc., that we should get straight on and treat this. That's another view of the proximal LAD, and his right coronary just had some diffuse mild atheroma. So, wire in the LAD, wire in the diagonal, they're both cyan blue wires, as that's the operator who was doing this case's preference, with a CLS 3.5 guide. 2.5 by 10 balloon pre-dilating the LAD. And then straight on, so the proximal lesion was pre-dilated with the same balloon, straight on to a 3 by 30 onyx stent. And it landed in some plaque, but kind of looked all right. And they then went on to stent with a 3.5 times 15, I think it was, proximal onyx stent. You're all spotting the deliberate mistake at this point. The focus at this point was on, are we getting that stent ostially, proximally, trying not to go too near the left main. Let's focus very hard on where we position that proximal stent. So that looks okay. Pot of the distal stent. I can see Eve getting uncomfortable already. It's not what you taught me, I wasn't there. And a pot, and we all know pot's important, of the proximal stent. And then we've got to take the side branch wire out. Diagonal's looking okay, so we need to take the side branch wire out. Next picture. So the side branch wire didn't come out, and the side branch wire was pulled quite hard because it didn't come out. And at that point, you can see the distal end of the side branch wire is coiled up. You know how the springy bit just coils up like a spring. It's not broken. The back end of the wire is still on the table. It's out at the diagonal. It's coiled up behind the stent. So at this point, a number of things are tried. What you can see on the screen there is the third thing that was tried. The first two things that were tried were a fine cross over the back end of the wire, trying to free up the wire tip and wiggle it out. That didn't work. A 1.2 and then a slightly bigger balloon over the back end of the wire to try and loosen it up, and that didn't work. And this is a telescope or a guide liner, I think a guide liner, again, trying to help with that and loosen it up. And you can see something going on with that proximal stent, and probably something going on with the distal stent. There's a couple of hours and a lot of pictures that I haven't included. You can see there's no wire in the main vessel at this point. So I don't know how clearly you can see what's going on, but there's something slightly odd looking in the end of the guide catheter at that point, which isn't wire, which is the stent, exactly as the front row are pointing out. The stent is unraveled, the proximal stent is unraveled and undone and hanging out in the left main. So, as steps taken so far, so as I say, we've tried the fine, or they've tried the fine cross, and the guideline is to take out the trapped wire. They've tried to balloon, and their next move was to call a friend and then another friend. So, ideas? Wire it and crush the whole thing. Okay, the issue with that, you may see better in the next picture. It's not all in the left main, it's in the aorta. So you can see there, and actually it's an onyx stent, and you know that that's made as a long wire, and this long wire is completely now unraveled. Some of it's still in the proximal LAD, and the rest of it, there's actually, when you look at the pictures very close up, there's actually quite a big loop of stent all the way around. Call a surgeon. We're not in a surgical centre, Shazia, sorry. We could, they'd take about an hour and say no, so no, we can't. But yes, you could transfer to a surgical centre, yeah. Yeah.
It is the structure of the onyx stent that has caused all this. When you pull the wire, the onyx is a coil stent.
Yeah.
It just pulled out.
Well, it's the operator that's caused it, not the onyx stent. But yeah, I see what you're saying.
I'm not blaming the stent, but I would say you pull it out, the onyx is...
It's unraveled and uncoiled, yeah.
A solution is just to take a loop and extract completely the stent from the aorta.
Because a snare, you mean?
Yeah, this type of stents, which is is easy to remove completely. By mistake, I removed one. So it's the Medtronic stent is easier than other stents to remove completely, to extract from the coronary artery.
So one of the operators who was called to help did have a go with the snare, and it's always quite nice calling a friend, isn't it? Because you're feeling awful, but your friend's going, I get to use a snare, I never get to use the snare. So the friend came along and tried to use a gooseneck snare, which didn't work, and then a tulip snare, and just couldn't get any grip on any of that fine material that was hanging around. Just couldn't grip it at all. Any other ideas?
So the guide catheter cannot engage the left main any longer?
Yes, I think the guide catheter can, but the stent is
But then
is
if
out.
the guide catheter can engage, you just put in a looped wire into the LED, no matter from where it goes, from the side of the strut or whatever. Then start dilating with small balloons and reconstruct the whole LED with long stents.
But what are you going to do about the bit of stent hanging out in the aorta?
Up to the left main ostium. The one part of the stent that is hanging in the aorta, that's not going to obstruct the coronary flow.
Okay.
So once we can reconstruct up to the ostium of the left main,
Yeah.
the patient is safe.
Yeah.
And then we can decide.
Yeah.
I would
comment.
I would do the same. I would wire the left main. Right now, you don't have anything wired, so I would be so worried that you get an obstruction of the left main, a thrombus or anything with all the material you have there. So I would be very, very scared with that picture.
Yeah.
So I would wire it. I would then balloon it and stent it up and forget about what's hanging out in the aorta.
Dr. Kursandi?
Yeah, I would pray first. then you can try wiring it. I suspect the stent doesn't allow you to engage properly to get a wire down. Put a second guide catheter and get a snare and pull that thing out.
Yeah, I think the second guide is probably a better way to go. Try to do, trying to wire, getting the guide close and all those things with the stent deformed like
more.
that is probably going to be impossible. So yeah, second guide and try to snare. They're probably way to go.
Yeah,
I
so that
had-
was, sorry.
I had a case very similar like yours. So I put a wire again, 2 wires, and then I used a bioptome for biopsy. And I took the wire with the bioptome, so it helped.
Ah, okay, yeah. More grip than a conventional snare.
yes.
Yeah, okay.
Helen, show us what you did.
Yes.
until
Oh,
the
yeah,
end.
well, yeah. So second guide, as you say, and it was the second guide I think they were trying to snare it with to start with, and a wire down the vessel at points. And then we decided, my colleague decided to try the 3-wire technique and managed to get 3 run-through wires down to the distal LAD, entangled them with the whole material that was coiled up in that proximal LAD, and managed to pull the whole lot out of the left main, of the aorta, and into the arm, and up to the brachial, and then breathed a sigh of relief. But then the problems are not quite over, but at least they're in the arm and not in the coronary vessels. So, sorry, jumped ahead a bit. So there's this mesh of stenty, wiry stuff in the brachial, and it won't go into the sheath. So what my colleagues then did was try to upgrade to a 7 French sheath in the arm to see if they could pull that material back into the 7 French sheath, and it still wouldn't go. So they called our vascular surgical colleagues, who are usually really quite enthusiastic now that we don't call them very often. But they were a bit like, well, yeah, it's fine, just leave them, we'll take it out tomorrow. I'll put them on the emergency theatre list and I'll take it out tomorrow. And they were happy with that to start with. So with that in mind, back to a guide from the left radial, which was where the second guide went in, to see what was going on up here. So now the proximal stent is removed, the distal stent is really mangled. And there's a bit of distal stent that's kind of, I think, twisted around like a sweet wrapper by the wires that have been pulling on it that I think were twisted. So that needs redoing. So wire to the distal vessel through, and I think, everyone thought they didn't mind whether it went through or to the side, but actually it went through. Some ballooning of that area. It's not letting me advance, oh, where we are. Some ballooning of that area, 2 more stents, and a final result. And then the 7 French sheath that had put in the radial artery wouldn't come out. So after all of his meditation, 7 hours on, he got intense spasm in his arm and the 7 French sheath would not come out. So they tried fentanyl, verapamil, nitrates, papaverine, wouldn't come out. So called friendly vascular surgeon back again and said, how about tonight? How about? And so he took the patient to theatre and took the sheath out and took the bit of stent out in a 10-minute operation, which we always forget is really easy from the radial for a vascular surgeon. It's not a problem. So he marked where it was, took him to theatre, and he had an uneventful recovery. This is the Terumo model that they show us how to do the 3-wire technique, and they had actually been into our lab a few weeks before handily, and everyone had a practice session, so that was quite useful. Sorry, there's sound effects on that. So these are learning points. My fellow put, don't push, don't pull. and don't double jail a wire if you're dealing with a proximal lesion, which I think Nicola referred to earlier. The final slide. So as usual, the patient where you've caused an awful complication is the most grateful patient ever. And he sent lots of Christmas wishes and said, thank you to the wonderful NHS, and I'm back doing my karate and you're all amazing. And even though, anyway.
Excellent. This is why we need to continue this kind of session with Women as One. It's really innovative, and thank you for wonderful presentation. I think we should try to vote now. If somebody can give us guidance on how to vote. Yes, while we are voting, yes, Valeria kindly accepted to share with us what is the Women as One organization.
Yeah, thank you very much. I'm a spokesperson. I was asked to present you some insights of the Women as One organization. There was already a great success. I was part of it last year, and I'm honored to be part of it as well this year. Can I have my slides? So as you know, Women as One is an organization, and it was founded by Roxana Meran and Dr. Claude Maurice. They don't need any kind of introduction. That was in 2019 with one goal, which was to promote women and to offer women technician opportunities. So the approach of Women as One is to, first of all, amplify, to give voices promoting individual talents, but how to do that, not just put women in front, but support them throughout some educational program, throughout funding, mentorship, and organizing a professional network, and unify, connecting healthcare professional. How did Women as One do that? There was creating a talent directory. We will see what's a talent directory in a few seconds, throughout some important programs and promoting some messages of equality. So I want to stress out what the talent directory is. First of all, it's a great global network. More than 2,300 women physicians, where every physician can insert their skills and their expertise area of interest. And that's from both sides. So that's important for women physicians, but also for organization, because organization in industry, they can look up in this web directory, and they can find and reach out to physicians, for example, to set up a trial or set up any kind of collaboration. As you see, the talent directory is not focused only on interventional cardiology, but has a wide, broad areas of expertise, cover all area of work. So this is the message of inclusivity, also for undeveloped areas. And the programs. I was part of the program as an attendee. Some women who presented their cases today were also part of the program. Alaide was also in this CLIMBS training program. There was a really unique experience with a small group of attendees and really experienced world-renowned experts. And we had the chance as attendees to show our cases, our clinical case, and get some feedback from experts. Escalator Awards. This is a program where all women can apply, propose their research programs, and after a careful evaluation, some of them will be funded and they will be carried out. And the RISE is a program which started just last year. This year is going to be held in London, probably during the ESC. So apply for it if you have any chance to go there, because this is something not really conventional. This is a program to develop some soft skills which are not usually taught during our medical university, our medical courses. So it's something else which can really add on our talents and promote a message of equality, stressing out what does it mean to have parental leave, promotion, research, and radiation safety. And as you can see, this organization has grown during the years. Since 2019, we already have, as I said, more than 2,000 women physicians, a lot of opportunities to learn and then to shine. And also, as we know, it's really important to fund some research program in order to provide new evidence. So thank you for your attention.
So thanks, Valeria. So for the one of you who did not vote yet, you just have to use the barcode. So try to do a picture, a photo, and then there will be the possibility to go to the vote. I don't know if we give some other seconds, maybe to have everybody voting. Okay. So maybe we can see the result.
Still counting.
Okay. Maybe still someone is voting.
I think, Alaide, as you did last year, probably we should thank all the participants, because it's not easy to stand up there and present your worst case, really tough complication. So it's thanks to all.
To share experience, it's all about sharing experience, and clearly complication, unfortunately, happened to all of us. So the winner, can we see again the... Okay, so the winner with 78% actually was jailed out or how to get out of it, Helen? It was a brilliant presentation, clearly.
I ask you a privilege is to give the gift myself to Helen.
Give it. It's okay. So
First of all, you have to say that
father.
to Shabazz that he's a friend. Don't worry, he can come next year if he wants.
Yeah, thank you very much. Bravo. So we'll have short break now, and I would like also to thank Alaide, who worked hard this year to make this session possible. Thank you, Alaide. Short break, and we come back.